Good afternoon, good morning, good evening, wherever you are. My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to this public health conversation. These events are chances for us to engage collectively with issues of consequence for health. Guided by expert speakers, we work towards deeper understanding of these issues to shape a healthier world. Thank you for joining us for today's event. In particular, thank you to our co-hosts from the Milbank Quarterly. Thanks also go to our Dean's office and the marketing and communications team, without whose work these conversations would not take place. This conversation is the second of a three-part series convening contributing authors from the Milbank Quarterly special 100th anniversary issue titled The Future of Population Health, Challenges and Opportunities. Thank you to all who joined us yesterday for our first session. Today's event will focus on the difficulties facing population health in the years ahead. I look forward to learning from our speakers today as we discuss the future of the field. I'm now very pleased to introduce today's moderator, Barbara Moran. Barb is a correspondent on WBUR's climate and environmental team. For 25 years, she has worked as a science journalist covering public health, environmental justice, and the intersection of science and society. She has written for many publications, including New York Times, New Scientist, Technology Review, and Boston Globe magazine, and produced television documentaries for PBS and others. She was a Knight Fellow at MIT and twice awarded the National Association of Science Writers' highest honor, the Science in Society Award. We are delighted to have Barb and the rest of the panel join us today. Over to you.
Thank you, Dean Galea. It's always a pleasure to do these panels. They're so wonderful and interesting, and we have a wonderful lineup today. So let me introduce our four speakers. They will then each give a presentation, and then we'll have panel questions and open questions for the audience. So first, we will hear from Georges Benjamin. Dr. Benjamin has served as Executive Director of the American Public Health Association since 2002. He came to APHA from his position as Secretary of the Maryland Department of Health and Mental Hygiene. Dr. Benjamin of Gaithersburg, Maryland, is a graduate of the Illinois Institute of Technology and the University of Illinois College of Medicine. He is board certified in internal medicine and a master of the American College of Physicians, a fellow of the National Academy of Public Administration, a fellow emeritus of the American College of Emergency Physicians, an honorary fellow of the Faculty of Public Health, and an honorary fellow of the Royal Society of Public Health. I'm always sort of in awe when I read these bios after hearing mine, but okay. Next, we will turn to Magdalena Cerda. Dr. Cerda is a professor and director of the Center for Opioid Epidemiology and Policy at the Department of Population Health at NYU Grossman School of Medicine. She obtained her doctorate from the Harvard University School of Public Health in 2006 and is a former Robert Wood Johnson Health and Society Scholar. Her research focuses on the effects that state and national drug and health policies and overdose prevention programs have on substance use and overdose trends, and on the ways the urban context shapes violence. Welcome, Dr. Cerda. Then we will hear from Matteo Farina. Dr. Farina is a postdoctoral scholar at the University of Southern California, Davis School of Gerontology, and will be an assistant professor in human development and family sciences at the University of Texas at Austin in fall 2023. His research interests include life course origins of cognitive and biological aging, examining race inequalities in later life health, and evaluating social determinants of health, especially education. Supported by an NIA K-99 grant, his current work examines the role of epigenetics in impacting cognitive health and aging in later life. Welcome, Dr. Farina. Finally, we will hear from Amruta Nori Sarma. Dr. Nori Sarma is an assistant professor in the Environmental Health Department at Boston University School of Public Health, where she studies the relationship between environmental exposures associated with climate change and health outcomes in vulnerable communities. Her previous work has examined the impact of heat waves and air pollution on health in vulnerable communities in India, South Korea, and across the US. Her current research aims to understand the impacts of interrelated extreme weather events on mental health across the US, utilizing large claims data sets. She also has an interest in evaluating the success of policies put in place to reduce the health impacts of climate change. All great work, thank you. Dr. Benjamin, we will turn to you first, and can I please ask the other panelists to make sure that they are muted? Thank you.
Well, thank you very, very much. Computer scientist Alan Kay has often been quoted as saying that the best way to predict the future is to invent it. And so as we start trying to think about population health in the future and thinking a lot about what does that infrastructure need to be for us to actually make that happen, some of those ideas that we need to invent, we already see. So for example, we know that the operating environment that we expect to be in is fast science, fast data exchange, fast communication, including all the challenges around disinformation, as well as hopefully good information being out there. Issues around a changed legal environment where people that are have historically not been involved in the policy world and engagement with public health, more engagement of the public, more engagement of judges, more engagement of the legal profession each and every day. A lot of the things we thought were settled no longer in terms of public health powers will be settled. I think it's going to be important for us to think about the issues around health information, the fact that we will hopefully once and for all have a health information IT highway. We have the technology, the tools to do it right now, but our systems, as you know, are not linked. And there's a lot of work being done to put these systems together so that we can have that fast data exchange and we can have much more better situational awareness on a population basis. And that includes getting data that is broken down very quickly by gender, race, ethnicity, sexual orientation, where you live, maybe even at a granular level, so that people can make data-driven decisions. We know that getting data in the same format for that data to be exchanged, so that data in one system is exactly captured the same way in data in another system, or at very least, we're able to extract the data so that we can make very good comparisons between those data systems. Thinking about what the workforce is going to look like. Obviously, the first thing we need to do is once and for all define the public health workforce, and that's going to change. We saw during COVID that all range of people saw themselves as part of the public health workforce, and to some degrees that's good, but trying to define what that core basic workforce that we need for a good system remains elusive, and we're hoping that that will get ironed out over the next couple of years. And that also includes having the capacity to do good enumeration of what that public health workforce is. And then, of course, continue with good training and skills, but even more specifically, recognizing that we need to have better skills at policy making, better skills at working in a political environment, much better skills that we actually utilize in risk communication, much better IT skills as those of us who are aging out, as they say in this profession, and the young people come in, the big gulf between our IT skills and our social media skills and our ability to engage in the virtual world are going to change. And so we're going to have a lot more opportunity to engage in this much more robust society. And of course, increasingly, this whole issue of genetic forensics and personalized medicine migrating itself into personalized public health, and then trying to think about what that means from a population perspective, where you'll be able to actually target therapies and interventions based on not only someone's phenotype but also on their genotype, where they live, and a whole range of metrics can be used to try to improve and deliver population-based interventions in a more targeted way among different groups. And of course, all the appropriate oversight from an accreditation perspective. Obviously, I see more and more people getting credentialed by the National Board of Public Health Examiners, health departments accredited by the Public Health Accreditation Board, a lot more engagement and interdiction between all of those oversight and accreditation boards, and elected leaders demanding that those types of certifications are required now to both do the work and to basically prove that you're qualified and credentialed to do what we need to do to protect the public's health. Increasingly, this whole issue around a whole of society engagement. I think, again, one of the things the COVID-19 pandemic taught us was the importance of a whole of society work. And so that means partnerships and building those partnerships that are enduring across the various sectors is going to continue to be important. And the whole idea of working a lot more efficiently with elected officials who better understand the role of the social determinants of health in making data-driven decisions. And so the decisions that they're making are no longer just political decisions or economic decisions, but they see that health both a political and an economic decision that has to be integrated into their processes. And then finally, this whole issue around funding. We continue to have challenges with what I call the yo-yo funding, where funding is robust after a big event and then rapidly goes away, and we never really build sustainable systems. I think in the future, we're going to see a lot more return on investment analyses, where people then understand that this upfront investment in population health, in prevention, in wellness, has an extraordinary return on investment each and every day. And when the economics are done from the COVID pandemic, and we begin to see more and more around where prevention made sense, prevention saved lives, and prevention saved money, we're going to be able to make that case a lot more efficiently in the future than we've been able to make in the past. So this is going to be an extraordinary time as we look forward. But having that infrastructure around population health is absolutely essential to deal with these things. And it's not just infectious disease, but it's chronic diseases. It's injury, it's disability prevention, to the extent that you can undermine and prevent a particular kind of disability. Those kinds of things we're going to see more and more of as we go forward. So let me stop with that brief introduction and turn it back over to our moderator.
Thank you, Dr. Benjamin. That was so interesting. I already have this long list of follow-up questions for you. So this will be a really exciting discussion. Okay, next we're going to turn to Magdalena Cerda, Professor and Director of the Center for Opioid Epidemiology and Policy, the Department of Population Health at the NYU Grossman School of Medicine. Okay, take it away, Dr. Cerda.
Thank you so much. Can you see my slides?
Yes.
Great. Thank you, everybody, for being here and for inviting me to present this work. This work is done in collaboration with Dr. Noah Kravchik of NYU and Dr. Catherine Keyes, Columbia University. So unfortunately, the United States has the unique distinction of being the country with the highest rate of opioid overdose in the whole world. In fact, in the past year, more people died of an overdose, mostly driven by opioids, than any prior year in recorded history. The overdose epidemic so far has gone through 4 waves. It started in the late 1990s with this push, particularly by the pharmaceutical industry, combined with professional pain societies, to think of opioids as a safe, non-addictive, humane alternative way to treat chronic non-cancer pain. And that really led to the proliferation of the use of opioids to treat chronic pain and to overprescribing, which contributed to a rise in overdoses involving commonly prescribed opioids. Then we had the second wave, which started around 2010 and was really characterized by a shift from prescription opioids to heroin. This was partly due to the crackdown by the federal government and state and local governments on prescription opioids, which made them harder to obtain. And this was combined with an increased availability of heroin and a drop in the price of heroin. The third wave began around 2013 and was driven by the introduction of fentanyl and other illegally manufactured synthetics into the illegal drug market. The notable thing to really realize here is that fentanyl is 50 times more potent than heroin. So what we're really seeing here is an increase in overdose deaths driven by a predominant product, which is highly potent. Currently, we find ourselves in the fourth wave of the epidemic, which is still predominantly driven by opioids, and particularly synthetic opioids, but increasingly in combination with stimulant drugs such as cocaine and methamphetamines. Now, when we think about and reflect on what do we do about this crisis, I think it's important to think back on the successes we've had so far, on some of the challenges, and use those to reflect on opportunities for future action. So I'm going to be talking about successes, challenges, and opportunities using the framework of prevention, levels of prevention. And so in terms of primary prevention, I'm particularly focusing on strategies for the reduction of supply and demand, focused around prevention of opioid misuse and opioid use disorder. In secondary prevention, I'm really focused on evidence-based treatment for opioid use disorder so that we can improve the health of people with opioid use disorder. And finally, in tertiary prevention, I'm focused on harm reduction, which is focused on meeting people who use drugs where they are in order to reduce the serious morbidity and death associated with some types of drug use. So let's start with primary prevention. So we've definitely had some successes in primary prevention, and they've focused mostly around supply reduction. And so, for example, the publication of federal opioid prescribing guidelines, the adoption of state and local laws to regulate opioid prescribing, and most currently, the litigation against the pharmaceutical industry did reduce high-risk opioid prescribing and did reduce and then stabilize the rate of overdose deaths involving prescription opioids. So we could call that a success. Unfortunately, these same successes had some unintended consequences. And so this restriction in the access to prescription opioids happened without sufficient access to evidence-based treatment for those people who had developed opioid use disorder. And also it happened without offering effective alternatives to treat pain. And so the restriction of the prescription opioid supply without these alternatives, I think, really contributed to the transition into heroin and other drugs in the illegal market, and contributed to the second wave that I talked about, to the rise in heroin overdoses and then to the rise in synthetic overdoses. And so I think that leads us to what I think are the opportunities. A lot of these successes and challenges are due to the focus of primary prevention, particularly around supply regulation. And what this tells to me is that we need to now shift to really think about regulation of demand, that is, prevention of demand for opioids and other drugs. In order to do that, I would really call for the need to invest in primary prevention strategies that address the upstream drivers of drug misuse, so that we can not only prevent initiation of opioid use right now, but we can also prepare to proactively prevent the next wave of the epidemic, and that may be driven by another type of drug. And so some of these upstream drivers that I would call for a focus on include job and housing loss, adverse childhood events, and incarceration for drug use. Some of the strategies that I think we really need to focus on here are, for example, economic and social policies that buffer against job and housing loss, investment in early intervention programs and horizontal prevention programs targeted at adolescents that try to prevent and address adverse childhood events, and finally, really decriminalization of drugs to prevent the adverse intergenerational consequences associated with incarceration for drug use. At the same time that we think about primary prevention, it's really important to think about treatment in terms of secondary prevention. And here I'm talking about evidence-based treatment, which involves the use of medication to treat opioid use disorder. We're talking about buprenorphine, methadone, and naltrexone as the three types of leading medications. Unfortunately, right now, approximately 80% of people who meet criteria for opioid use disorder don't have access to evidence-based treatment. And some of that is due to the fact that the treatment system is regulated to an extent that other types of medications are not regulated. In spite of that, we have had some important successes, which we should celebrate. First, with Medicaid expansion in some states, insurance coverage for people with opioid use disorder has substantially increased. And second, recent, and I'm talking about in the past few months, recent changes in federal regulations have really helped expand access to treatment. So some of these changes include, for example, the removal of a special waiver needed to be able to prescribe buprenorphine, the allowance of telehealth to induce and prescribe buprenorphine, and finally, the expansion of what are called methadone take-homes. The latter is particularly important because up until now, in order to access methadone, people had to go to licensed opioid treatment programs, which were few and far between across the country, and they had to go almost every day in order to be able to get the treatment. Imagine how crippling that is in terms of being able to start and stay in treatment. At the same time, some important challenges remain, particularly because federal and state regulations continue to restrict who can prescribe and where people can access medication. If we think, for example, about methadone and the restriction of prescribing and dispensing only in these opioid treatment programs, rather than an expansion to other types of prescribers or other types of venues such as pharmacies. Second, there is this persistent stigma that really affects the willingness of providers to prescribe these medications, and also the willingness of people to enter and stay in treatment. And finally, partly due to stigma, partly due to strict regulations, there's also a limited number of providers who are willing to prescribe treatment for opioid use disorder. At the same time, I really think we have an opportunity to build on success here. We can build on these recent changes in federal and state regulations to continue to remove the regulatory barriers to prescribing and accessing treatment, for example, by allowing methadone to be dispensed in pharmacies. We can invest in training and incentivizing providers to increase the number of providers available, remove bureaucratic hurdles for access, such as the removal of prior authorization for being able to access treatment. And we can also invest in low threshold programs, for example, the provision of treatment in mobile vans, in churches, in community settings, to really meet the most vulnerable people where they are. Finally, as we talk about primary prevention and we talk about treatment and secondary prevention, we really need to think about harm reduction. Right now, we're talking about a drug overdose epidemic that is driven by a highly lethal drug, highly lethal types of drugs. And so because of that, harm reduction is really important. Now, in the past few years, there have been some notable successes in the area of harm reduction. These include expanded access to naloxone, which can effectively revert an opioid overdose, the increased availability of drug checking products, such as fentanyl test strips, so that people who are consuming drugs can make an informed decision about the types of drugs that they're consuming and reduce the risk of dying from drug use. And the authorization and opening of syringe service programs that are highly effective venues to be able to access harm reduction products. We know that all of these successes have helped reduce morbidity and mortality from drug use. At the same time, of course, there are important challenges, and in particular, access to naloxone, to drug checking equipment like fentanyl test strips, and to clean syringes, among other harm reduction services, is still continues to be limited by state and local laws that restrict or criminalize access to drug paraphernalia. However, I really, again, think that there's an opportunity for future innovation in this area, in particular by focusing on calling for states and local governments to fully decriminalize drug paraphernalia, to expand capacity for drug checking, to allow, given the lethal nature of the current drug market, to allow for safe consumption spaces where people can consume drugs under supervision, and really to promote access to a safe supply so that we can reduce the unnecessary number of deaths that are occurring. To close it out, again, I'd like to end with highlighting some of the successes include our ability to curb high-risk opioid prescribing, the expansion of access to evidence-based treatment, and increased investment in harm reduction. But I'd really like to highlight that people continue to die at record numbers from overdose. And so we have the tools at our hand to be able to address this problem. We really need a multi-pronged strategy that includes investment in primary prevention to focus on addressing the social drivers of drug use, elimination of regulatory barriers to treatment and harm reduction services, and investment in low threshold treatment and harm reduction services, so we can really get these services to the people who most need them. Thank you to my co-authors. Thank you to Milbank Quarterly, and thank you for this opportunity to present today.
Thank you, Dr. Shada. That was a very sobering presentation, but also a lot of hope in there. So thank you for that. Looking forward to talking more about it. Next up, we have Matteo Farina, postdoctoral scholar at the USC Davis School of Gerontology and a research affiliate, the Population Health Center at the University of Texas at Austin. You can take it away, Dr. Farina.
Perfect, thank you. And my slides are visible, correct?
Yes.
Okay. Right, so first, thank you for having me here today. This is going to be a little bit more, I think, high level and focus on education. So the title of the talk is just Dynamic Changes in Association between Education and Health in the United States. And then Mark Hayward is actually the lead author on this. We've collaborated on this together. Just want to recognize him really quick. So the role in education in shaping health has been consistent, persistent, and sort of profound in its impacts. It's sort of one of the sort of scientific truths that the more education you have, the better health you will have at all stages of life, but particularly, especially in later life. However, less attention has sort of been given to the idea that this association is in fact dynamic. Right, so like the ways in which education impacts health is going to be embedded into larger sort of structures, and some attention has sort of been shining its light on there, which I'll allude to in this presentation, especially when thinking about state policies and changes. But some of the key questions that we have here is how and why does this malleability exist? So in other words, how is the relationship between education and health going to be contingent on, your communities that you live in, your family structures, the states and the policies that you're exposed to? And two ways that we're kind of thinking about the ways in which education and health has been dynamic, especially in the United States, has been sort of thinking about the historical changes that we've seen, especially with the growing educational inequalities that we've seen over the last 30 years, and also the explosion of knowledge that we've had since basically, right, the 1800s, but really the 1900s, when it started kind of implemented in terms of hygiene and health policy. So the two areas that we primarily wanted to focus on, the two questions that we had, whereas how is education association and health contingent on the historical changes, the scientific advancements, and the institutional context. And then the second part, which I think there's been less attention to, but is probably going to be driving more of this research in the coming years, is thinking about the different parts of the education distribution that are most impacted. So just kind of to allude to what I'll be showing later on in this presentation is that it's really the low educated that have been greatly impacted in the last couple years in terms of the changing policies that we've had in the US. So here I want to just provide a here's model that is available in the manuscript that kind of lays out the foundation of the ways that we're thinking about health and education. So at the very bottom, right, we have early life course factors that impact educational attainment. Educational attainment then impacts your adult mechanisms, right? So this leads to good jobs, valuable networks, which then impacts your health. Most of the research has largely focused on sort of this educational attainment through adult mechanisms and health. And then now a burgeoning area of research, especially in the last like 15 years, has been sort of institutional and social context, right? So thinking about the ways that economic opportunities, educational opportunities, scientific knowledge are all impacting sort of that relationship between educational attainment and some of the adult mechanisms that we're seeing. And then where we want to kind of introduce part of the conversation is thinking about at the very top that actually these institutional contexts are also dynamic and changing. So there is a change in both scientific knowledge and institutional changes that have occurred that are going to be impacting this as well. So just to kind of lay the foundation for why education and health matter, which I'm sure many here already know, but basically the idea is that education allows for the deployment of personal resources that are highly flexible, complementary, and overlapping. And here are some of the examples of it. Think about health literacy. So like, that smoking's not good for you, you'll stop smoking, right? The more education you have, we've seen this association, the less likely you are to smoke. Employment opportunities, as well as your sense of control and agency. And these are all going to be overlapping with one another. And that's where most of the research has been for the last 30, 40 years, right? But it is sort of developing. So the ways that I wanted to kind of point out that there's a dynamic nature between education and health, especially from a demographic perspective, actually drawing on some of Isaac Sasson's work, along with Mark Hayward, who have looked at the ways in which life expectancy has changed over the last 30 years and how it's actually, there's a growing inequality that's occurring. So in this figure, in figure 2, that's been part of this manuscript, you can see for each of these groups, which is white men, black men, and black women, on the x-axis is the years, right? And on the y-axis is life expectancy. If you look at the 1990 for each of these groups, it's the lowest difference between education groups. And then over time, it just completely widens. And once again, this is actually pre-COVID. So, right, so it'd be interesting to kind of think about how that might have changed or even widened even greater during those last couple of years in this period. And you see this consistently across all groups. And the reason behind this is either, eventual stagnation or even deterioration of health among low educated and continuing improvements among those who have college. So this kind of points to the fact that this education relationship with health is not necessarily stagnant, right? But when we're thinking about some of these demographic shifts, we should really think about the contextual influences, right? But a lot of the contextual influences on health, the robust and multi-layered, we can think about the ways that these are impacted at the community level as well as the state level. But a lot of these approaches have been ahistorical, right? So not taking into account the changes that have occurred for those different contextual units that we're kind of looking at. But there is an emerging literature on the ways that context shapes the dynamic relationship, especially when we're thinking about state health policies, which I'll go into the next slide and kind of go over a little bit. And then there should be really two primary ways that context influences health are both the policies and the technologies that are available, right? And whether or not this is being made available to everyone, or there are certain sorts of groups that are being affected most by this combination. So in particular, one of the questions that we think is important to ask, especially going forward, and one of the questions that we kind of brought up throughout this manuscript is why have resources and risks been redistributed to not only advantage those most advantaged, but also being pulled from the least advantaged, the least educated, least advantaged, because we're actually seeing worse health than they had, 20, 30 years prior. So there's a concern there that improvements have stagnated or now they're worsening. So here, this is what you kind of pull into this idea is building a lot on Jennifer Karras-Montez's work and think about health disparities across states. So like as you can see on the left-hand side, there's increasing disparities across state levels between Oklahoma and Connecticut are the two sort of examples here that were produced in this paper. And then if you look at the right-hand side, which is important here, is that you actually see a much wider difference and gradient in the less than high school, which are the solid black dots in terms of the mortality risk, than you actually see among the more than the high school educated. So the idea here, and this has been sort of found, is that the state policies are actually, if you're college educated, you can live in many different states and see the advantages across them. But if you have less than college or high school or below, you're actually going to see a lot more fluctuations. You're going to be impacted a lot more by the state policy context in which you live. That's going to be shifting that. So part of the question that we have is, we've seen these dramatic health improvements in the US population, especially from the 1900s to 1970s, right? There's been institutional investments in scientific and technological advancements that have been coupled with a lot of social policies that were trying to reduce poverty, right? And we can see this, and also we can see this with sanitation efforts and sorts of things. So this kind of led to an explosion, right, of health and life expectancy over the 20th century. It was actually every single group, although educational inequalities existed, every single group was improving over this period. But since the 1970s, we're actually seeing growing inequality and increased variability in life expectancy among less educated, right? Which is to kind of bring the attention that there's less of the sort of coupled pathways that puts them together on better longevity and health, and in fact might be to this group's detriment. So a question that we kind of had over and over again is, does the rising tide lift all boats, right? And that's for you to decide, but I would say at this moment, no. What we're seeing from the 1990s is that there are continued improvements, but it's going to be among certain types of groups, which is leading to this growing inequality. So discussion, to kind of just end, so we have enough time for the next speaker in the Q&A, is just to go over, so there's change over time, and these changes in variation longevity are overlapping. So we're seeing these changes in life expectancy among the less educated and most educated, and we're seeing the changes in the variation among less education that are driven by states. So we're kind of arguing here is that context matters, as well as especially when we're thinking about the changes that we're seeing at the national level, right? In some of these trends that are sort of starting to concern. And then also is the impact of educational health is far from exogenous, right? It's not just that education is going to be giving you good health, right? But in fact, that they're going to be embedded in these larger socio-historical changes and institutional arrangements. So that's just suggests that we have to be thinking about both individual and institutional resources and who's available to that if we want to actually improve health of the entire population, not just a select group. So we can think about the less educated in here and really focus on them. And especially as population health continues, that's going to be a major concern if they continue to see worsening or deterioration of their health. And we can think that they are particularly vulnerable to institutional contexts. And we can think about this in terms of the opioid crisis that the United States has experienced since the 1900s, as well as what has happened with COVID, right? With drops in life expectancy and just sort of experiences that they've had. And then lastly, the part that we really wanted to emphasize is that health improvements among the less educated require sort of the increase in both personal and institutional resources, right? So with the kind of bring back agency and the idea that there's personal resources that can be deployed to improve your health. And also it's not just one policy, but it's going to be a bundle of a whole bunch of policies that are going to come together, right? Since these effects are going to be sort of complementary and kind of run together. So on that note, I'll kind of skip over limitations. We can talk about that later, right? But these are important things to kind of consider. It is actually happening at a global level as well, not just in the United States. And then if you have any questions, feel free to email me. Thank you. I'll turn it back to the moderator.
Thank you, Dr. Farina. That was very interesting. My question list is growing here. So next up, we have Amruta Nori Sarma, who's an assistant professor at the Boston University School of Public Health.
Wonderful. Thank you so much. I just want to make sure that you can see my slides.
I can.
Great. So thank you for the introduction. And I'm really happy to be talking with you all today about our section of this special issue, which looks at human health and well-being in a warming world. And I really want to acknowledge my co-author for this section, Dr. Gregory Wallenius, who is the director of the Boston University School of Public Health Center for Climate and Health. So as kind of a background framing discussion for our talk about climate change and health, I want to provide this historic versus current perspective. So I think historically, especially at the origins of our recognition of the real scale of the climate crisis, we thought about climate change as primarily an environmental issue. I think a lot of people probably remember in the late 80s, the early 90s, some of the discussions around, charismatic micro and mega fauna. So looking at some of the endangered species that were most threatened by advancing climate change. And I think that there's been a shift over the course of the last few decades, which provides us with a really excellent framing for the discussion today, towards climate change as an issue of human health and well-being. And so that's kind of the context where I want to place us for today. And corresponding with this growing recognition of the health implications of ongoing warming and climate change, the number of adults who are concerned about the potential health impacts of climate change has been steadily rising as well. And so here I show some publications and data from the Yale Program on Climate Change Communication, which shows the estimated percentage of adults who are worried about global warming. And as we can see in 2021, the national average was around 65%. And there's some variation depending on region, depending on state, but by and large, the percentage of adults who are concerned about climate change and global warming outweighs those who are unconcerned. And this also has corresponded with an increase in the availability of information around climate change and also the human health impacts of climate change. So this is from a 2016 publication that shows the exponential growth over the course of 1980 to the mid-2010s around publications and peer-reviewed publications especially that focus on climate change. And you can break this down by different sectors. Are we focused on the ecological outcomes associated with climate exposures? Are we looking at health implications? But by and large, there has been an explosion in the research and in the data available around the implications of climate during this time frame. And I like to share this figure, which is adapted from the CDC's third national climate assessment, because I think it does an excellent job of showing the variety of different exposures in the center that are associated with extreme climate events, including things like extreme weather, rising sea levels, increasing carbon dioxide and other types of pollutants, and rising temperatures. And then in the center, the middle section of this figure, you see things like severe weather, air pollution exposure, changes in vector ecology, et cetera, that are associated with those increased climatic exposures. And then in the outermost portion of this figure, you see the host of different human health implications, both chronic and acute, that are associated with exposure to these different climatic extremes. So I want to spend a minute talking about climate vulnerability and health equity as well, because we know that exposure to climate change is definitely an equity issue. And one of the ways that we can characterize this in the US is through the lens of, urban development and issues such as redlining. So for those who are unfamiliar, redlining was a policy that was implemented in the early 1900s in different communities across the US, where the homeowners and loan corporation would determine the eligibility for different funding mechanisms of different neighborhoods. And by and large, this was an issue of structural racism, where communities that were primarily Black or minority were issued lower credit ratings compared with primarily white neighborhoods in the same urban environments. And some of the current studies that we've seen illustrate that there are meaningful climate relevant differentials in exposures that still persist even today, that are associated with some of these structural issues that have historically been experienced in these different communities. So temperature provides a really good example where we see urban heat islands and the centers of different cities experience temperatures that can be a few degrees higher than suburban or rural environments. And oftentimes these extreme heat areas tend to be concentrated in those areas that received less investment starting in these early developmental stages. But it's not just limited to the US. Climate change and health equity is a global issue. So we know that globally, those who are experiencing the most dramatic impacts of climate exposures are not the same as the people who are contributing to the emissions that are leading to climate change and continuing to create warming trends. So this figure is from a 2007 paper by Jonathan Patz and colleagues, and it shows in the top the countries of the world weighted by their contributions to greenhouse gas emissions. So as we can see, Europe and North America are very heavily highlighted in terms of the levels of carbon emissions that are going out into the environment. And the bottom panel shows the regional distribution of only 4 climate-sensitive health effects. So this is mortality associated with malaria, malnutrition, diarrhea, and inland flood-related fatalities. And here we can see very clearly that the places that are highlighted as the most heavy emissions around the world are not the same as the places that are experiencing the greatest mortality-related impacts. And this is only looking at 4 of the most common climate-related mortality outcomes. So I want to maybe do a little bit of a throwback to one of the previous talks, because, similar to some of the other public health relevant fields, we can kind of think of strategies for solutions to climate exposures in the same primary, secondary, and tertiary levels. So when we talk about primary, what we're really talking about is mitigation, climate change mitigation. And this is the strategy of reducing greenhouse gas emission sources or enhancing the sinks, which are the places that capture greenhouse gas emissions, in order to slow or potentially halt the overall warming trend associated with climate change. When we talk about secondary, we're really referring to adaptation strategies. So this is preparing communities to proactively face ongoing exposures to climate extremes. And then, of course, we have response, which I would characterize as tertiary, which is improving community resilience in the wake of their experience of climate-related extreme weather events. So I want to talk about these in just a little bit more detail, providing some examples, and also tie it back to the health implications of each. So there are some health benefits of climate mitigation, and we think of this traditionally now in a co-benefits framework, where we see that interventions in order to reduce the overall global warming trend and reduce overall climate change will have meaningful health benefits as well. And so this is what we refer to as health co-benefits of climate mitigation. One example that you can think of is that in reducing carbon dioxide emissions from fossil fuel combustion, we will necessarily reduce other harmful air pollutants and thereby potentially achieve some benefits to human health from the perspective of respiratory illness, cardiovascular disease, and potentially mortality as well. Another example that we could think of is improving urban design and green space, particularly for those communities that are experiencing some of these urban heat islands, may have knock-on effects for both physical and mental health, particularly in some of the most vulnerable communities. In terms of adaptation to climate change, extreme heat provides us with a very relevant and a good example because of the broad amount of work that's been done around extreme heat exposures in different communities. So one of the items that I want to highlight as a potential adaptation solution that's been employed relatively effectively both across the US and around the world is the development of heat action plans, which generally incorporate some component of advanced forecasting when extreme heat periods are likely to occur, alongside some interventions in order to try and reduce the overall health impacts of extreme heat exposures. So this can include things like opening cooling centers, which are available public spaces with air conditioning for communities that may have lower access to air conditioning in residential facilities. And this has been relatively successful in different contexts around the world. Another effort on the part of different cities is to map heat vulnerability. And this has led to some of the things that I was mentioning earlier around identifying those communities, particularly in urban settings, who are the most vulnerable to extreme heat and also experience the highest exposures to extreme heat. Another trend that we're seeing around the US especially is the appointment of different chief heat officers in different cities whose responsibility is to make sure that these heat action plans and some of these different efforts to identify the most vulnerable populations and make sure they're receiving the services that can help them to cope in periods of extreme heat. This is centralizing and coordinating efforts into a single office that is primarily focused on this very climate relevant extreme weather. So I'll wrap up here so that we can go forward to the discussion. I just want to mention, as I've said before, climate change presents a large, and I would argue one of the largest global health challenges that our society faces. The future health implications of climate change are going to depend on how we mitigate, adapt, and respond to ongoing and future climate change. Climate change is also occurring against a backdrop of both rapid urbanization as well as existing structural issues, some of which I have mentioned today. And there will be many health consequences as a result of ongoing climate change, but I also view this as an opportunity for sustainability, for equity, and also for the promotion of better health and well-being into the future. With that, I want to once again thank my section co-author, Dr. Wallenius, as well as the team at the Milbank Quarterly, and my fellow panelists and the co-authors of this special issue. Thank you.
Thank you, Dr. Nori Samar. That was really interesting. Can I ask all of the panelists to please come back on camera here and turn the mics on? So we're going to be starting the discussion part of the program. People are welcome to put questions into the little Q&A box, and we will get to them in a few minutes. I'm going to take the moderator's prerogative and ask a few of my own questions first. And it struck me, though this session is about sort of major challenges in public health, and you certainly laid them out. I think we have opioid use, an aging population, climate change, education. And what struck me was that with all of these, we seem to know some of the answers, right? We seem to have a lot of the answers in hand, but there's trouble implementing them. And this is, I think, most striking in Dr. Serda's talk about the opioid, mitigation of overdoses. And I was wondering if I'll ask you first, Dr. Serda, but then everybody else could weigh in. How do you see in the divided sort of country that we're in, the divided political landscape, what do you see as sort of standing in the way of implementing some of the things that we know we should be doing, or what else is standing in the way?
Yeah, that's a great question. I think stigma is a huge driver here. Stigma about people who use drugs, stigma about medication to treat opioid use disorder, the idea that, it's replacing one drug with the other, stigma about harm reduction, the idea that you're enabling more people to use drugs and it's just going to get worse, right? So all of these beliefs, I think, really hinder our ability to enact policies and to invest in some of these critical life-saving services like harm reduction treatment.
I was going to ask if you see wide differences across the country in places that are more willing or less willing to implement some of these things.
Yeah, I mean, I do think, I think it probably runs parallel to differences across the country in willingness to or investment in climate protections, in investment in the social welfare system, right? An investment in public health in general. I think it's, the same political, social drivers that lead to different beliefs about public health in general that also contribute to the disinvestment in these kinds of evidence-based practices. However, I would say that there's actually a lot of reason for hope. I think like in the past year, we've seen such change, right? So for example, with treatment, we saw, there were emergency measures implemented because of COVID to expand access to treatment. And now we've seen actually permanent changes that have resulted from that. Also, in the federal overdose prevention strategy, for the first time ever, we're seeing harm reduction as one of the main strategies, and the harm reduction language just pervade the whole document. That's a huge step forward. Now, there's obviously tons of room to move forward, but I do see some areas for hope for us.
Good. All right. I like hope. Fantastic. Dr. Nuri Sarma, similarly, do you see, the political or sort of cultural things sort of standing in the way of doing climate adaptation or mitigation? And maybe it's like similar to what Dr. Serda was saying, is that it seems to be maybe getting a little better. I don't know. How do you see it?
Yeah. So I would agree. I think that a lot of the same structural and social factors that Dr. Serda mentioned are also very impactful on, climate mitigation, climate adaptation. But I think that also the nature of the conversation has really, the changing nature of the conversation around climate change has really helped. And I mean that in two different ways. So maybe the first one I'll characterize as the discussion of the intergenerational impacts of climate change. When you talk to people about their health, but particularly when you talk to people about their children's health, that seems to be very impactful. And then the other thing that I want to say too is that communities are facing climate change, whether they strictly call it by the name climate change or not. We see communities experiencing extreme drought, flooding, wildfire, a lot of the extreme weather exposures that are associated with an ongoing trend of climate change. And so communities, whether we want to continue having the discussion specifically around climate change itself, communities are starting to prepare for these extreme events that they're experiencing. And that is a very real, component of public policy that's ongoing, whether or not we're continuing to have a debate around climate change specifically itself.
That's interesting and hopeful. So good. Progress. Fantastic. Dr. Farina or Dr. Benjamin, anything else would you like to add to that?
Yeah, let me just add the fact that it's very clear that we have two different parts of our nation with two different views on the role of government. How should we spend the dollars that we have? I think there are still challenges on debates around what the facts are. I do believe that the fact debate is beginning to change a lot because people are beginning to, it's kind of the emperor has no clothes scenario, where people were following in a crowd's way things which they absolutely knew were not true, but they were just going along with their tribe. And increasingly, we're beginning to see people that are breaking that tribe. So the tribe bubble is being busted. And with that, people are now getting a variety of information that may be counter to the very narrow bit of and targeted amount of information they were getting before. So I think that with that we're seeing some change there. But I do think that one of our challenges is that we often try to speak to all communities with the same words and not really speak to people where they are through the lens in which they see the world. And that requires some work, and that requires us changing the way we approach people. So to the extent that we can speak to people from where they are, treat them with respect, and bring them along, I think we have an opportunity to change society a lot quicker than we've done in the past. But the opportunity is clearly there.
That's great. If I could follow up on that, one thing that you mentioned in your talk, Dr. Benjamin, about meeting people where they are, and we're also facing this in the media, is sort of, traditional media, is the rise of social media and how people get their information. And I was wondering if you could expand a little bit on what you mentioned in your talk on that, about how are you seeing sort of public health messaging changing, or what ways does it need to change, maybe, in order to sort of get people where they are, reach people where they are?
Yeah, I think the first thing we need to do in public health is become comfortable using social media.
Mm-hmm. You can do some TikTok. You can do it.
Yeah, well, particularly our governmental folks, they have been held back for a variety of traditional governmental reasons. No financial investment in the systems, no financial investment in people to do it. If you're going to get someone who's going to, the people who are anti-vaccine, for example, I'm not talking about the people that are hesitant around vaccines. I mean the people who spend their day trying to undermine the efficacy of vaccines. That's what they do. And we've not recreated a core of people who are committed to getting the facts out. That requires commitment, that requires training, that requires funding. And until we're committed to, in effect, go after them in an appropriate way, recognizing there is a First Amendment and respecting the First Amendment, they're still going to win because there's a small number of people with a large bullhorn. And the truth of the matter is there are many, many more of us than they are of them, meaning people that follow the science and follow the facts. Our bullhorn is just a little smaller. In fact, it's a lot smaller. And our commitment to aggressive engagement is not as committed. So we have to be as committed as they are, in fact, maybe more so, and sort of become domineering in the conversation. And then we need to, quite frankly, release our young people who are very good at this stuff, and let them do the way. They need guidance so they don't get in trouble, but we do need to do that. And I think once we do that, we can expose people who are living in a world in which they only get their news from one source, and expose them to more pieces of information. People tend to make the right decision if they're given the right information.
Getting a lot of amens in the chat, Dr. Benjamin, to what you're saying. Dr. Fried, I wanted to turn to you for a second, and you can add on to that if you want. But I was also very struck in your conversation about this widening gap among the educated and less educated in since the 1970s. And I was wondering, and then I want to follow up with the rest of the speakers. I was wondering if that plays out that way in other countries as well. You had some interesting stuff about states, but I was wondering about, is it that stark in other countries? And if so, or if not, or what can we take away from that?
Okay, and just to clarify, so the 1970s was really the institutional policy shift. We really saw the widening gap since the 1990 period, right? Which is sort of the figure that I showed. I just wanted to emphasize that part.
Thanks.
So I think which is important because I think there's a delay, right, when we're actually going to see some of these things start to manifest. And then to answer your question about whether or not we're seeing this in other countries, most of the research, most of the research has been focused on the United States. Some we can see this. I believe there's a couple studies in Norway and a couple other places where you actually do see also widening changes when it comes to like functional limitations and disability things that are going on. But more recently, and this is work that is not yet published, right? But I've seen kind of go through. There's been looking at other countries in the low and middle income country sort of category, and you are actually seeing some of those widening gaps as well. Not to the same extent that as the United States, because that's kind of what we've seen as sort of surprising and very concerning, and there's been sort of a lot of attention given to that. But this is, I would say, it's no longer a U.S. phenomenon. In fact, because of the data that we're having that's being made available to look at some of these other places.
Do you, Dr. Farina, see any countries where that are successfully narrowing the gap, and any particular policies that you see out there that are successful? And then I'm going to ask the same question to the rest of you for your fields.
So I don't want to, because I've actually been recently working on a paper that has over 48 countries, and I believe there are 4 of them. I can't think of them off the top of my head. I will have to, you can email me, I can definitely send you to them. But yeah, there were a few countries where the gap was either stable or slightly being narrowed. But I think that's really difficult to do, right? Especially in the world that we live in today, right, with the globalization and sort of the growing inequality that we've been seeing throughout many of these countries, even countries with sort of social and very robust social safety net systems.
Dr. Serda, I'm wondering if you want to weigh in on this sort of cross-country issue. We had a lot of questions coming into the Q&A about things that have been tried in other countries regarding opioid addiction and death, and things that have been successful.
Yeah, I think we can definitely learn a lot from other countries. So we know, for example, in the area of treatment, that medications to treat opioid use disorder are not as strictly regulated in other countries, like, for example, Australia, or countries in Europe or in Canada, as they are in the United States. And so, for example, different approaches have been tried, like integrating methadone into primary care, or allowing pharmacies to dispense methadone. And the studies have shown in other countries that has been highly successful. So I think we have a lot of lessons learned about effective ways to change our treatment service delivery system in the United States, based on the experience of New Zealand, Australia, Europe. For harm reduction, the same. So, for example, there's safe consumption sites, which are places where people can consume drugs under supervision, and they can be connected to a range of other services. These services have been implemented in more than 100 countries across the world with positive effects. We're just seeing the first couple of centers open in the United States, in a publicly sanctioned way, but we have a huge, long way to go. And that's just one example of the types of harm reduction services that have been implemented elsewhere, and from which I think we can learn here.
Dr. Nouri Sarma, any climate change interventions in other countries that sort of jump out at you as really inspiring and successful?
Yeah, so climate change is a really interesting one, right? And I think the reason why is because it is hard to be successful on a country by country basis, like climate change doesn't really respect our political boundaries. And so if all societies don't come together and decide we are going to limit ourselves to 1.5 degrees centigrade of warming, then it's not feasible. And so I think it's hard on a more micro scale. There have been successful examples of some of these adaptation strategies that I think have been working fairly well in different communities. I've done some work with, the Public Health Foundation of India and other collaborators in the India context to implement these heat adaptation plans in different communities across India. There has been a really great heat action plan that combines weather forecasting and issuing of heat alerts in South Korea. And we've looked at the relative effectiveness of that program across 7 different major cities in South Korea. And it turns out that it is relatively quite effective in reducing mortalities associated with different health outcomes during periods of extreme heat. And in particular, highlighting certain vulnerable populations that might be the most impacted by those extreme heat periods in those communities. And so I think, there's an ongoing push to help communities adapt in different ways that make the most sense for them. One of the things that I like to mention is that in the work that we were doing in India, the New York City heat adaptation plan was a really big model that was used by collaborators in the Indian context. But in New York City, one of the recommendations is go to a public cooling space, go see a movie, or go to an air-conditioned restaurant during an extreme heat wave. And for vulnerable populations in urban India, that's just not feasible. You can't tell people to go to a movie theater during an extreme heat period. And so the alternatives that were recommended were things like going to the nearest green space or a local park, or providing access to drinking water during those extreme heat periods. So even within those adaptation plans, the local context is really important to make it relevant for those communities. And then in terms of the response, I do think that one of the most powerful things that I've seen so far is bringing clinicians into the conversation and the dialogue around climate change and the impacts that that's going to have on patients. I've seen a really wide array of responses when you talk to doctors about the impacts that heat or other exposures may be having on their patients. In our recent work on mental health across the US, we received a range of responses from, oh yeah, I see increasing rates of emergency department visits for mental health because of heat, all the way to the other side of the spectrum. I have no idea what you're talking about. I don't think that extreme heat leads to increased need for mental health services. I don't see that relationship. So I think it's, starting to talk with those clinicians about what they can do to provide support for their patients. So really, I think it kind of depends on which part of the solutions scale you're looking at.
Super interesting. Dr. Benjamin, do you have any sort of global public health interventions that really inspire you or that have sort of jumped out that we should think about doing here?
Well, globalization has done some interesting things. So COVID has exposed the myth that everything that we do in the United States is the best way to do it. It also has allowed us to recognize that there are many other ways to do things, and other nations, quite frankly, who have either invested in the infrastructure to do things, or have just, quite frankly, just figured out a neater way to do something, that we can, utilize their understanding and their knowledge. This is something that the whole world had a similar experience, and yet the outcomes around the world were all quite different, with, quite frankly, some of the most resource-intense countries not doing as well as some of the lower income countries. I should say probably some of the more middle income countries. The poorer countries did not do very well overall. Nonetheless, I think that there is now a more openness to both share, to engage, to learn from one another. And I think that public health, which has always had that as one of its mantras, can participate and help accelerate that. When I talk to all of my other colleagues in the World Federation of Public Health Associations, so these are all the other associations that look like the American Public Health Association and all the other nations of the world, there's over 70 of them. Our experiences in many ways are very similar. We had some of the same distractors. We had some of the same things that we learned to do well. There were a lot of back channel discussions all through the pandemic where people were sharing information. And we actually saw our governments at some level beginning to do more collaborative work. So the question is, how do we accelerate that kind of learning and get policymakers to recognize that we are in a global society now, and what happens in one nation can no longer not be paid attention to because we can wall them off. We cannot wall ourselves off, whether it's climate change or substance misuse or violence or infectious disease. We just cannot. And if there's nothing, it's clear now that that's the case. And so now we have to prosecute, as they say, that argument around the world and come together to do this. And I was recently part of a group with Dr. Galea, which looked at the social determinants of health and trying to use an understanding of the social determinants and data to get policymakers to make more data-driven decisions to address broad societal issues. And it was a phenomenal report that came out of that work. And to the extent now we can get policymakers to pay more attention to that, I think this whole issue of globalization will make a lot more sense to everyone.
Interesting. Yes, I'm all for data. Paying attention to the data. Fantastic. So I want to remind the audience that they can put questions in the Q&A, and I will get through as many as I can. I'm going to turn to some of those now. There's a bit of a tough question in here for Dr. Serda that I'll read out. Dr. Serda mentioned limiting the supply of drugs has been somewhat helpful. I'd like to ask her, can you please talk about the current political discourse on fentanyl supply? For example, Republicans use this crisis to talk about the border. What do you think is needed to limit supply of this drug?
Yeah, that's a great question. So I would say that it's a complicated answer, right? Because, so for example, when states and the federal government enacted laws to basically regulate opioid prescribing, and that restricted the prescription opioid supply. And so that was a success in the sense that we saw, high risk opioid prescribing go down. But at the same time, we saw, right, overdoses involving other drugs go up. And so to me, what that says is that focusing, if you just focus on supply, you're never going to be done. The problem is it's just going to be like a moving target, right? Like now then it was prescription opiates, then it became heroin. With then it's fentanyl, it will be something else, right? And so closing the border, all of these supply interdiction policies, I think are not going to solve the problem unless we really address the demand issue. We're actually going to have is a worsening of the problem, because it means that getting drugs will be made more precarious, more dangerous, which means people are going to be accessing drugs in a more unregulated way, which means they're going to be more likely to die. So I think we need to shift the conversation from supply to really thinking about what are the ways that we can address demand, and that we can address these persistent drivers, right, of use, and the fact that it's not a one drug issue. Today it's opioids, but tomorrow it could be something else, and we keep having this problem. Unless we address some of these underlying social drivers, I think we're going to keep having this problem.
Yeah. I'm going to just stay with you for 1 second and follow up with another audience question, which is kind of, I know if you're saying we need to deal with the underlying drivers, but since for the question for somebody who's immediately in the middle of it, asking to address the presence of trank in the current drug supply. And can you explain what that is for people who don't know? And that how do professionals and people prepare for that and for whatever's coming next? How do you look down the road a little bit while trying to repair the other side of the road at the same time?
Yeah, it's a huge issue. Yeah. So trank, it's xylazine, otherwise called trank, is a sedative used for animals to treat large animals, to sedate large animals. And so it's used in veterinary medicine, as well as in animal research, research used for things like finding cures for cancer. Unfortunately, it has transpired into the illegal drug market. It started out in Philadelphia, and we saw some reports, I think starting a couple of years ago, of xylazine in Philadelphia, but now we're seeing increasing reports in other places around the country, like for example, in New York City. And we still have a lot to learn about it. We know that the issue is less about people dying from overdose related to xylazine and more related to wounds associated with the use of xylazine. But again, I think this speaks to the precarity of the drug supply. And when it becomes difficult to access one drug, then these other potentially other products emerge. I think, one of the ways that we can prepare for that is the use of recent data. So this is something that I think really struck me with COVID. With COVID, we were seeing data on COVID cases like on a daily basis, right? With overdose, we have data from 2 years ago. It's hard to forecast and predict what's coming down the pike when your data is from 2 years ago. So I think investing in data structures and in much more recent data and being able to develop data infrastructure at the local level so that jurisdictions can forecast what's coming down the pike will be really important. And then also equipping our community services, our harm reduction organizations with funding so that they can respond to these things that they're seeing on the ground. Often it is the local harm reduction organizations, the local health departments that are seeing these new products, and they're equipped to be able to respond to them, but they need to have the resources to do that.
Great, thank you. Such a complicated and interesting topic. Here's another audience question, and I'll send this over to Dr. Nori Sama first, but then other folks can weigh in. Interested to know if the speakers are aware of any work in the space of climate change impact on infectious diseases like tuberculosis, since more displacement and increased malnutrition are both top risk factors for TB. I guess I've heard a lot about climate change and sort of vector-borne diseases, but I haven't heard much about that.
Yeah, so I think that there's a growing awareness of potential for malnutrition, especially with food supply issues that might be impacted by drought or by extreme precipitation, or even drought followed by periods of extreme precipitation, which is also quite problematic. So that's the context in which I'm aware. I think, as you mentioned, by and large, what I've seen in infectious disease epidemiology associated with climate change is more looking at the increase in ranges or the change in the ranges of infectious disease vectors. A good example is ticks in the northeastern US and the increasing range of ticks and Lyme disease infections in different communities. So that's what I'm aware of. I don't know of any research specific to tuberculosis, but I have seen malnutrition and food insecurity as one of the, I think it has several different pathways as well. Food insecurity goes through infectious disease, potentially also through the other pathway that I've seen is through conflict, increases in conflict over scarce resources.
Right, sure, of course. Yeah, all these converging things. Dr. Benjamin, do you want to add anything about that? Climate change, TB, other disease emergence?
I don't know about tuberculosis specifically, but obviously that continues to be a a big issue, and this migratory pattern of change in weather, because people are really not paying a lot of attention to that. They are paying attention to the changes in the weather, but they're not necessarily paying attention to the changes in the infectious disease risk, projections in their communities. And for those people who are practicing clinical medicine, nursing in those communities, they need to be aware that diseases that weren't commonly in their community are going to be more prevalent. And so they should not be surprised when they see those more particularly vector-borne diseases. And if you're a veterinarian, the impact on the animal stock that you're taking care of, you're going to see those change as well.
Oh, wow. I hadn't thought of that. That's interesting. Huh. And that goes back to what Dr. Norisarma was saying before about how clinicians at this point are kind of all over the map a little bit as far as thinking about personal health and then climate change. So that's an interesting place to see where it goes. Here's an audience question for Dr. Farina. What perspective should we take when considering education? I find it simplistic, not me, the person writing the question, find it simplistic to count the years of formal education only, given the institutional context you mentioned that would render educational experiences very different for different populations. Are there alternative ways to measure and gauge education and equal terms?
So the reason we focused, first off, I actually agree, right? Education is multifaceted. We should think about quality. We should also, right, the years that you attend also are not equal in terms of even days sitting in school across groups. And we've seen this, especially in the United States, for Black and white Americans, right? Especially in the 1960s and such, which I have actually worked on some of that stuff, so I can speak to a little bit. But I think the reason that we use educational attainment is it's a very strong and robust marker, right, of strong and robust prediction of health in later life. It's something that we do collect data-wise at the population level. So we're able to kind of look at what's happening across countries and then within the United States especially. But I do think it leaves out the question about what does quality mean and how that might be impacting health. I will say that as far as the ways that education impacts specific groups is something actually very near and dear to me. And I have a whole other area of work that is thinking about even in the South during 1960s and 70s and how that impacted sort of the educational experiences of minoritized populations and how that differed. And we are seeing an effect of that on some of these, especially cognitive health and actually some biological aging and some of these other health outcomes that is concerning. So I think for this perspective, we just retained sort of the educational attainment part just because that's the easier one to go after, and that's the data that's actually the most robust, I think. But there is a burgeoning area that's thinking about what does education mean for specific groups, and also even what does education give specific groups, right? So we're thinking even about the ways in which someone's able to translate their education to benefits. It's going to differ, in the United States, especially from gender and racial structures that we have, right, kind of imposed. And that's a kind of necessary and important consideration in thinking about some of these intersections. But, that's I think that's a whole other area.
Great, thank you. I think Dr. Galea is going to pop on here in about 5 minutes. So I wanted to ask one more question of the group. And it sort of comes off of something Dr. Benjamin said at the very beginning, which I'm going to misquote this, but it was something about if you want to know what the future is, you have to invent it. So I wonder if you all might just give me 1 minute just thinking about, the next coming decades of public health and what each of you would like to most see happen that could do the most good for the most number of people in your field. I'll let you go first, Dr. Benjamin, because you brought it up.
Sure. I'd like to see the average person in our country becoming much more health literate, much more scientifically literate. I think it will dramatically improve their understanding of their health and their ability and capacity to improve the health of others.
Okay, I can get behind that. Fantastic. Dr. Serdo, how about you? Make the future.
I would like to see a much stronger investment in public health infrastructure in this country. I think that could have really cross-cutting effects across all of these areas of health and beyond, and climate, and destigmatization of problems such as drug use disorders. So I think that's one of the ways that we can really have a sustainable impact on population health overall.
And Dr. Farina?
I agree with that. I think there needs to be more investments in institutions. One thing I was going to say is, like, especially in taking the historical perspective, the United States did actually a really good job, right, in the 20th century in terms of this type of institutions and support that we gave. We can kind of look to ourselves a little bit and thinking about how we can bring some of those lessons out. And especially with the things that we learned about, like, health equity and globalization, some of these changes. So I think we can I would like us to kind of reflect on what we've actually done a good job of and how we can bring that into the future.
Great, a nice optimistic thought there. And Dr. Nori Sarma.
Yes, I agree with everything that my co-panelists have said. I guess maybe the one that I would add is, in addition to health literacy and better public health infrastructure, an ethos of caring for our neighbors and caring for the impacts that people outside of just ourselves face. Really strong ties to community. I think that's very essential for ongoing good health and for putting together solutions to these really complicated issues that we're facing.
Yeah. Okay, so science literacy, more funding, better community, be nicer to each other. I think that'll solve everything. Thank you all very much. I see that we're out of time because Dr. Galea has come on. So I wanted to thank everyone for joining us today from all over. And thank you to our wonderful panelists. It was really an honor to moderate this discussion, and you've really given me a lot to think about. So thank you.
Well, I really have very little to add to that. I actually, first of all, want to echo the thanks to Drs. Farina, Benjamin, Nori Sarma, Serda, and to Barbara for excellent moderation. I want to thank the audience. Those are some outstanding questions and comments. Really, with an engaged audience, I actually learned as much from the questions as I did from the answers. And I want to thank the speakers for their concluding words. I actually do think that the prescription that came up at the end, which is a genuine investment in these solutions, but coupled with a doubling down on compassion and a commitment to well-being of communities, is a solution that would move us forward substantially. So thank you all for surfacing that, and perhaps thank you in particular for ending on that and ending on a tone of hope. For everybody who was here today, join us tomorrow for the third part of this sequence of seminars linked to the Milbank Quarterly's 100th anniversary.